Line sepsis, prevention and management. We'll talk about prevention and then about management. So this is a schematic from Dennis Mackey, who's probably the father of all bloodstream infection research. When you look in the dictionary, the medical dictionary, Dorland's or one of those dictionaries under bloodstream infections, there's a picture of Dennis Mackey. So there are two ways that IV lines get infected. One is when they get inserted. They get infected at the, it shows how late in the day it is. I keep on pointing at that thing as if you'll see it. They get infected when the line is inserted because of bacteria that are on the skin. So a lot of the interventions that we do are aimed at decreasing the risk at the time of insertion of introduction of bacteria into the bloodstream. And then the other way they get infected is through the intraluminal. So this is extraluminal along the outside of the lumen, and this is the intraluminal when the hub is manipulated or new lines are put in or fluids are connected. So it turns out that short-term catheters are more infected by the skin at the type of insertion, and that's why most of the bundle of interventions that we're going to talk about is really aimed at the insertion time, not the maintenance. And then long-term catheters are infected based on the intraluminal route, and that's more of a maintenance issue that's less well studied. And I'll show you some ideas about how to prevent those. So these are guidelines that came out in 2011. The initial guidelines came out about 9 or 10 years before that, and then these came out again. These are from the CDC, from the Healthcare Infection Control Practices Advisory Committee, or HICPAC, and you can see that one of our co-hosts, Dr. Mazur, is one of the co-authors. So, question. You are revising your ICU's vascular catheter infection prevention guidelines. Which of the following measures should be included? Nasal screening for Staph aureus and decolonization for patients in whom you're going to place a central venous catheter. Guide wire facilitated replacement of catheters in use for more than 1 week. Preference for the operating room rather than the bedside for vascular catheter insertion. Preference for iodophore for skin site preparation, or removal of all idle catheters. So, excellent. Almost all of you got the answer correct. Removal of idle CVCs. What's wrong with the other answers? Number one, screening for Staph aureus and decolonization. There are some data about this for surgical site infection prevention, and a lot of hospitals do that routinely for patients in whom foreign bodies are being inserted, like orthopedic prostheses or valves. But there's no data, as far as I know, about reducing risk of CVCs. Guide wire facilitated replacement, people have studied this, and it's actually the opposite. When you change over a guide wire, you increase the risk of infection because bacteria that may be sitting latently in that track are pushed into the bloodstream as you change the catheter. So it actually may increase the risk. Preference for the OR rather than the bedside. This has been studied and there's no difference. It's really the prep at the site. It's not the rest of the area. And then preference for iodophores. In randomized trials where chlorhexidine is compared to an iodophore, the chlorhexidine does about twice as good in terms of reducing risk of infection. Probably has to do with the fact that for an iodophore to work, iodophores are iodine that are complex to an organic carrier, and it's released, the iodine is released from the organic carrier and active as the iodophore dries on the skin. No one waits for it to dry. They put it on and they put the catheter in, and so there's no free iodine there, so it's really not active. Whereas chlorhexidine, which is preferred, is active instantly. It's very quickly active. So I think it has to do with a timing issue more than the product themselves. And this is the use of bundles to prevent infections. And again, These are largely aimed at insertion prevention, in fact, preventing insertion-related infections. Each of these things that I'm going to go through has been studied in a randomized controlled trial. There are at least 1 or 2 randomized controlled trials to support each of those bullets, but no one knows the contribution of each component to the bundle as a whole. So, for example, this is an ensemble. If you just did chlorhexidine skin prep and didn't do any of the other things, could you reduce infection rates almost as much? No one really knows that. They just know that each of these measures works in randomized trials, and so they recommend doing all of them. So educating personnel has been studied. Is the catheter needed? No catheter infection. Avoiding replacement as a strategy. I talked about the risks of going back through the... in fact, people have studied, there's a study, I think it was in critical care medicine, of neomorts. So neomort is in newly dead. So this was done in Europe, where I think in the Netherlands, they took patients who had just died and dissected the catheter site and showed that in the vast majority of them there were bacteria sitting in the track, and that if you had changed that catheter over a guide wire, you would have potentially pushed bugs in. Chlorhexidine skin prep, I mentioned that to you, maximum barrier precautions. There are 2 randomized trials showing that if you use a cap, a mask, sterile gloves, and a large drape, you reduce the infection rate more than if you don't have all of those components. Those are from teaching institutions. You've got to think that a really good intensivist can probably put in a catheter with a pair of sterile gloves and nothing else, just holding his or her breath, put it in, and you don't get an infection. But this is what the guideline is. And then the last thing is, should you use coated catheters? That is, catheters that are coated with disinfectants or antibiotics. How many of you in your ICUs routinely use coated catheters? So most people don't. When I ask why, I'm not an intensivist, so I'm not putting these catheters in, but when I ask our intensivists, they used to say it had to do with the stiffness of the catheters, and the catheters that were coated were stiffer and they felt a little bit harder. In part, it also has to do with cost. They're a little bit more expensive. And in fact, most people have no catheter-associated infections if they do the first 5 bullets on there. So they save the money and don't use the coated catheters. Some people are very insistent that if you don't use a coated catheter and you have even a single infection, then you've done that patient a disservice by not using the coated catheter. So, but most people do not use them because they think the other methods are good. How well do these guidelines work? They work amazingly well. This is trends just looking at MRSA and central line-associated infections. And you can see that MRSA, when the first guideline came out in 2001 to 2007, a 50% reduction in infection rates due to MRSA. As you know, the Keystone study from the New England Journal of Medicine that was done in Michigan, where like 108 hospitals had ICUs that participated. It wasn't a randomized trial. It was a before-after quasi-experimental style. But I think the median, or the mean or the median, maybe the median infection rate was 0 by the end of the study. So these are very, very, very effective measures. They don't do as well for long-term catheters because they don't address maintenance issues. I personally think that the maintenance issue can be addressed by cleaning your patients every day in an ICU with chlorhexidine. If you bathe the patient every day with chlorhexidine, you get rid of this fecal patina, which I think is a big source of the maintenance-related bloodstream infections. And this is a study that we participated in that randomized 40-some hospitals in HCA, the the Hospital Corporation of America, to one of 3 arms, and one of the arms was daily cleaning with chlorhexidine, and they showed that universal decolonization was more effective than targeted or screening in reducing MRSA and bloodstream infections from every pathogen. So I'm kind of curious, how many people in here do your ICUs routinely clean patients every day with chlorhexidine? About 30% or so. Okay. All right, let's talk about treatment. This is a guideline from 2009, which is, I'm going to go into in a little bit of detail because these are questions that you would be asked because you get these patients in your unit and you've got to decide what to do. So, first is definitions. How do you define a catheter-associated infection in these studies? I think that the most common thing is for people to culture the distal 5 centimeters of the tip on a roll plate. So basically what they do is they cut off the end, put it in a urine container, cut it off with a sterile scissors. It goes to the lab. The lab, when they get that tip, roll it over the agar plate, and more than 15 bugs are on the plate on the next morning. That's considered catheter colonization. And then if the same bug comes out of the bloodstream as from the catheter tip, then it's a suggestion that the patient has a catheter-related bloodstream infection, and it impacts what you do with that catheter. Using a sonication method, which very few labs do, you can take the tip, put it into broth. They sonicate the broth, which means they send, some sort of shock wave through it, releasing the biofilm from the edge of the catheter. And if there's greater than 10 to the 2 CFU per ml in that broth, then that's considered colonization, but people don't do that practically. And then this is an approach that is used in studies, but I don't think practically very many places do it. And that is drawing blood cultures from the hub and peripherally. So you draw blood culture from the hub of the catheter and peripherally, and you send them to the lab at the same time. The blood drawn from the catheter should have more bacteria in it than the peripheral blood, because you're drawing it from the site of the infection. So if the catheter is the site of the infection, that culture becomes positive 2 hours earlier or more and has more than 3 times as many bacteria in it. So people do this sometimes as research. In early days before transesophageal echoes, when we had to rely on TTEs, we had someone who had endocarditis, and we wanted to get a sense of which of his valves was infected, so we put a catheter in and sampled the blood over each of the valves and figured out which valve was infected, but also put a hole in that valve. So not always a good idea. All right, the most common pathogens. 60% are gram-positive, that's coag-negative staph, Staph aureus, and Enterococcus. 20% are gram-negative, largely E. coli, Enterobacter, Pseudomonas, and Klebsiella. And 10% are Candida. The Candida, we'll talk about, are somewhat problematic because of the choice of agent to use for Candida. The gram-negatives are becoming more problematic because of resistance, and in fact the gram-positives, at least in terms of the spectrum of drugs we use, we have the biggest spectrum of drugs probably for gram-positive bacteria. So if you look at the guidelines, there are these 6 key treatment decisions you have to make when you decide to treat a line-related infection. And so this should be, less and less of an issue in your institutions because you should see less and less bloodstream infections, but the ones you see probably are in more complicated patients and in more difficult situations. So the first decision is what antimicrobial to give, then how long do you give it, then do you use an antibiotic lock, what do you do about echocardiograms, and then when do you remove the device and when can you reinsert the device, particularly important for things like hemodialysis catheters. So I'm going to touch on some of these for which there are data. So the first is empiric treatment recommendations. How many here, if you're worried about MRSA, and I can tell you when they look at ICUs in the country, what do you think is the most common regimen? And I mean like 90% of patients who get antibiotics started in ICU get these antibiotics started. What are they? Vancomycin and piperacillin tazobactam, yes. So JAMA article recently where they looked at, I think, 183 hospital ICUs, and hospitals and ICUs in those hospitals. The vast majority of people get either Vanc and pip-tazobactam, or when there's a pip-tazobactam shortage, which there is periodically, Vanc and maybe cefepime, or Vanc and some other broad-spectrum cephalosporin. So how many of you still use Vanc when you're worried about MRSA? How many have changed to something else? So most people not. So vancomycin is what I use empirically when I'm worried about MRSA, and you saw that Staph aureus is at the top, near the top of the list of pathogens in line infections, and MRSE, coagulase negative, and MRSA. It's a terrible drug for MRSA, and some people use daptomycin if the vancomycin MIC is high. But I think still most people use vancomycin, even though it's bad, and even though the people make daptomycin, linezolid, ceftaroline, a bunch of other things are all pushing to replace the knee jerk, but still vanco. Gram-negative coverage is like politics. It's a local decision. So in some ICUs, you have problems with KPC. If you're at the NIH, during certain periods of time, you'd be worried about, should you give the patient colistin? In our hospital, it's not such a big deal, and pip/tazobactam isn't such a problem. But if you look at all bloodstream infections in ICUs across the country, and you look at the regimen that covers the gram-negatives the most reliably, if you want to cover gram-negatives at a 95% rate or higher, you have to use a carbapenem plus amikacin. If you look at bloodstream infections in ICUs across the United States. But most people just stick with pip/tazo until they know what the patient has or some other agent. Covering multi-drug resistant organisms, again, depends on the institution. Neutropenic patients, patients who've had multiple courses of antibiotics, someone who's had pip/tazobactam 2 courses already, and they get septic, you're probably not going to choose that as your knee-jerk therapy. If patients have femoral catheters, you have to cover gram-negatives and candida. There tend to be increased rates, particularly of candida, particularly since our patients are largely obese in the United States. There's a lot of obesity, and intertriginous areas are very moist and have lots of candida in them. That is the recommendation if you look at that guideline. Other indications for candida. So if you look at that guideline, it says people who have TPN, broad-spectrum antibiotics, hematologic malignancies, transplant, or they're colonized with candida in multiple sites. Treat them empirically for candida. And then the coverage. How many people use an echinocandin as their knee-jerk if they know there's candida in a bloodstream or if they're worried about candida? How many use an azole? How many use amphotericin B? So more people use an azole than an echinocandin. Okay. There is really no right answer there, except if someone's been on an azole for a while, you wouldn't use an azole. You'd assume they have azole resistance. And there are certain bugs like C. krusei and Candida glabrata for which an azole may have intrinsic resistance. But I think that's more ID board questions. All right. Question 2. In evaluating a CVC in a febrile bacteremic patient, which of the following elements contributes the least to a decision to remove the catheter? Erythema and purulence at catheter insertion site, femoral versus peripheral location of catheter, hemodynamic instability, positive culture without a focus of infection, specific pathogen recovered from the blood, the specific pathogen recovered from blood. So which one of those would you consider the least helpful? Oh, from now on? So now they're not going to do anything. They're going to score them. Just keep answering. They've got a tally, I guess, so that you can go home. All right. So the correct answer for question number 2. Oh. I see. They're not even going to bother to do their damn machine, huh? We don't need no stinking questions. All right, the correct answer is femoral versus peripheral vein location. Everything else on there is going to be on the next slide. If there's erythema and purulence at the catheter site, then you're worried about a suppurative phlebitis, remove the catheter. The patient has hemodynamic instability, source control, you think the catheter is a source, you'd want to remove it. Positive blood culture without a focus of infection, again, that suggests the catheter may be the source of infection, and the specific pathogen, some pathogens are harder to treat. So long-term catheters, and it's always a discussion with the nephrologists and with the oncologists about removing their long-term catheters. These are the indications in general guidelines: severe sepsis, suppurative phlebitis, endocarditis. Any bloodstream infection where the cultures are positive for more than 72 hours into antimicrobial therapy, particularly for Staph aureus, there is really a linear relationship between the longer the blood cultures are positive and the worse the patient does. So whether removing the catheter aborts that worse relation or not hasn't been studied as well, but that's the one thing you can do. And then specific pathogens tend to be harder to treat. Short-term catheters people tend to pull out much more readily because they're more easily inserted. The last bullet, I don't know that I've ever come across this, but this is in the guidelines, that Bacillus, Micrococcus, Propionibacterium, if they're not contaminations and they're really causing catheter-related bloodstream infections, it's hard to eliminate them without removing the catheters. All right, question 3. In deciding whether to give 2 rather than 4 to 6 weeks of antibiotic treatment to a patient with Staph aureus infection of a removed CVC, all of the important are important considerations. So the concept is that if you have Staph aureus bacteremia, there's a very high risk of endocarditis. That's based on a study from the 50s where they did autopsies on everybody who died of Staph aureus bacteremia, and there was a very high rate of endocarditis in those individuals. And since then, even though that was an autopsy study, so biased obviously, since then there have been a lot of studies that have shown that people with central lines and Staph aureus in their bloodstream, if they get short course therapy, 2 weeks rather than 4 to 6 weeks, they have an increased risk of coming back in the hospital with a valve infection. So of those, the thing that is least helpful is a tip culture with greater than 100 colonies, because we don't do roll tip cultures. 15 colonies would be the correct answer if we did a roll tip culture. All these other things are useful. A negative TEE at 5 to 7 days, history of an aortic graft, you'd want to avoid a short course. What the ID consultant recommends, I'll show you that actually the ID consultants do recommend things useful. And then resolution of fever and bacteria within 72 hours. That would make you use a shorter course, or let you use a short course. So these are bug-specific guidelines for Staph aureus. So I've divided them to coagulase-negative staph, into Staph lugdunensis, which is a coagulase-negative staph, but behaves like Staph aureus. In the past, most labs didn't speciate. Now that there are pretty simple laboratory tools for speciating staph, coagulase-negative staph, labs are doing this more and more when there's multiple positive cultures. So if you have someone who has 2 or more positive cultures, separate draws for coagulase-negative staph, and it's not speciated, you should ask the lab to speciate it, because Staph lugdunensis needs to be treated like Staph aureus. It's much more virulent. So coagulase-negative staph, you can see that it's really a short course of therapy, and some people don't even remove the catheters. They just give an antibiotic lock. Staph lugdunensis is like Staph aureus. Staph aureus, you generally remove the catheter and treat for 4 to 6 weeks, and if you're given a short course, those are the very specific situations in which a shorter course can be used. The catheter is removed, the patient doesn't have diabetes, which increases their risk, isn't immunocompromised, has no hardware, has a negative TEE, and their fever and bloodstream is better. Their blood cultures are better within 72 hours. And that's why doing a blood culture every day in patients with Staph aureus bacteremia is very helpful to determine duration of therapy. Because if you do it every day and they're negative within 72 hours, it helps you decide on shortening the course of therapy. What are the data that infectious disease consultants help you? You heard Dr. Mazur say, I think Silversai said, don't do it yourself. You know, this is a professional on a closed course. Don't do it at home. There are a number of studies. This is not the best, but it's the one I made the slide of because I thought it had the best figures. This is a non-randomized study, but people have done randomized trials. And basically they show that this is the percent survival. People who got an ID consult did better than those who didn't get an ID consult. And I've got to believe that even though it's not a randomized trial, ID consults probably are called on the sicker patients. You probably don't call them if the patient's healthier. So it actually is interesting that there's a statistically significant improvement in survival, and randomized studies have shown the same thing. So probably just like HIV therapy, for Staph aureus therapy, it's worth calling an ID consultant. I think the other place where it's worth calling an ID consultant is multi-drug resistant gram-negative bacteria, which can be very tricky in terms of they use colistin, they use combinations of therapy. What do you use? All right, so continuing the pathogen-specific guidelines, most enterococcal and gram-negative line infections get treated for 7 to 14 days. Day 1 is the day the first negative blood culture. Candida, usually people treat for 2 weeks. In some countries, they don't treat candidemia at all. They just pull the line out. The candida usually goes away. They don't treat it, but there's about a 10% risk of metastatic seeding, particularly with Candida albicans. And then if you have a complicated infection, so that's bacteremia or fungemia longer than 72 hours, endocarditis, suppurative phlebitis, osteomyelitis, people treat for much longer. Antibiotic locks are an interesting issue, and they actually can be used for catheter salvage, where you put some sort of disinfectant or antiseptic like alcohol or antibiotic into the catheter every 20 or 48 hours, let it sit there and work on the biofilm that's within and around the catheter. And sometimes you can salvage as many as 2/3 of catheters by doing this if it's a critical catheter that would be hard to replace. Echocardiogram guidelines. This is where in the past infectious disease doctors and intensivists differed. I think more and more intensivists agree with this now, that the bottom bullet is a TTE is inadequate to exclude endocarditis. The resolution is just not as good. And so if you really want to exclude endocarditis, particularly with Staph aureus and you're going for a short course of therapy, you need a TEE. For other pathogens, you decide based on the clinical picture, and if you do use a TEE, we usually wait until you're within about 5 to 7 days after the onset of bloodstream infection, because that's about how long it takes for the vegetation to grow to a size that would be measurable by an echocardiogram. All right, which of the following practices is specifically, which shouldn't you do? Qualitative cultures of catheter tips, alcohol for adjunctive catheter locks, waiting 5 to 7 days to do an echo, basing the duration of treatment for a line infection, or calling an ID consult. The correct answer is 1, qualitative cultures are not useful. There's no benefit in doing a qualitative culture. All right, this just shows you a recent study looking at actually putting ethanol locks in, and you can see I underlined the pertinent part, but about almost 2/3, 62% of patients were able to maintain their CVC for long term. So this is not necessarily routine. This is something you want to do for those special situations where you really need a long term. So people with short gut, where you need an IV catheter the rest of their lives. All right, a number of catheter don'ts. Don't culture the catheter tip unless it's removed for an infection. If you culture the tip and you get bacteria out of it and the patient doesn't have a suspected infection, you're not going to know what to do with it. Don't order qualitative cultures. If you're going to do a culture of a catheter, you want the last 5 centimeters, except for PA introducers, you want to culture there the subcutaneous. Probably the single best thing you can do to increase your rate of recovery in blood cultures is put more blood in the bottle. Fill it up to the line. There's a linear relationship between the amount of blood you culture and the percent that's positive. So if you culture half as much, you'll find half as many bacteremias. If the patient's not on antibiotics, a blood culture becomes positive, you get called, always reculture the blood before starting an antibiotic. Because if the patient's cleared the bloodstream spontaneously, which sometimes happens with coagulase negative staph, it'll save you a lot of trouble. Linezolid, for whatever reason, in a randomized trial with vancomycin and oxacillin, had more deaths in the linezolid group when they were treating catheter-related BSI. So if you look up the package insert, it says don't use linezolid for catheter-associated bloodstream infections. Thrombolytics are, as Dr. Mazur said about an earlier slide, I think he was talking about clots in the skull. You have to decide when you use them. I don't know of any randomized trials really of thrombolytics for bloodstream infections where the vein is clotted. And just like don't redo the C. diff, don't routinely blood culture except dialysis catheters. And then epidemics. Why should you care? Why do you even care about this? Well, I think it's early recognition to prevent more cases, and so that you can intercede, particularly when there's bad techniques that's leading to bloodstream infections, and also when there's diversion and contamination of narcotics. It's not unusual for someone to divert narcotics in intensive care units or on hospital wards. In that diversion product, the person who's addicted and stealing the narcotic from a drip or from a tube contaminates that site, and the patient gets bacteremia. Lots of articles written about it, and there's lots of experience with this, so this should be on your radar. Why don't I stop at that point and see if there are any questions. Thank you very much.